You're listening to the Sick and Good podcast. My name is Dustin Messick, RDN. I'm a cancer survivor.
My name is Dr. Colin Goodwin, and I'm a cancer survivor. We're discussing topics related to cancer treatment and recovery while promoting wellness.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment, and before undertaking a new healthcare regimen.
I'd like to welcome Dr. Ida Wong to today's conversation and just introduce her for the listeners here. She's an associate professor of medicine at the University of California, San Diego. She has practiced oncology and hematology for 8 years. So welcome, Ida. Thanks for being with us.
Thank you for having me.
Can you tell us about your career path?
Sure. Yeah, no, I'm a San Diegan, born and raised, and I decided never leave here. But I grew up here and then went to UCSD undergrad, and that's where I majored in biochemistry and biology. And I guess I was interested in medical school, but didn't feel quite ready to work or go to medical school or continue school. So I worked in Research Institute here in San Diego, which was a great experience to work in the lab. Made me realize I didn't want to be in the lab, but I had some great bosses there that kind of urged me. They were both physicians, urged me to go to medical school. And so that was my brief jaunt outside of San Diego. And I fell in love on the bus ride over across Park Avenue in New York City and decided to go to Cornell there for medical school and lived up in the Upper East Side for 4 years and went to medical school. And it was a great experience to see how the other side of the country lived, but came right back to San Diego, boomerang right back, and came into UCSD internal medicine here. I'm back in San Diego to be with my family. I went to UCSD residency and I did a chief residency year, which for internal medicine is an extra year. And then I continued on to UCSD hematology oncology fellowship and stayed on. So I work, all my clinical time is at the San Diego VA hospital in La Jolla, but I do research on the UCSD side and also work in the medical education with the medical students, internal medicine residents in the fellowship there. I'm actually the associate fellowship director for the fellowship. And so I have been at the VA and UCSD for 8 years now, and time seems to have flown by. And that's where I am at this moment and love my job.
Well, what made you want to become an oncologist?
Well, so that's a more long story of how I got there. But 2 days before Thanksgiving, when I was 16, I was diagnosed with acute myeloid leukemia. And that is really, I think, changed the course of not only my life for me and my family, but also just, I think, my career. Just remember these vivid spots in my memory, even though it's now a few decades since then, but being taken out of my class. And I was pretty athletic and I was getting these headaches and sleeping in class. And so my mom took me to the doctor, and from there I was hospitalized and bone marrow biopsy later, diagnosed with AML, which is not common in that age group. And things moved really fast. And although I received chemotherapy, the cure really is a transplant. And I was very, very fortunate that my sister was a full match. And I had a stem cell transplant up in LA less than 4 months after my diagnosis. And it's just funny because I think 16 is a very interesting and funny age to be in. You're not a young kid, but you're not an adult. So I remember these memories of sitting in the pediatric oncologist's office in San Diego in these like small toddler chairs and yet not feeling like I was fitting in. And then on the transplant side, I was really the youngest by decades amongst all the adults. And so it's a funny age, but I just remember a team of people, nurses, social workers, physicians who are just all really a family to us. And I think the transplant doctors, just because you spend the most time with them, kind of the biggest impression, they made the biggest impression on me. And I don't think it was a conscious effort to go into medicine. I think in school, I always liked math and science better than writing. And I mean, even in college, I used to envy my roommate who would write a 10-page essay in like 2 days while I agonized for weeks. Yet I loved math and calculus. So I think that was maybe already kind of the writing on the wall, but sort of and I even tried a lab, as I said, I wasn't quite ready to commit to anything and didn't feel like lab was my thing. But I think after some soul searching, I put my efforts into medical school because I really wanted in some way to really emulate what my physicians were to me and give back to a community that kind of gave me everything, including my life, but kind of a different personality even after. And I tried to like everything from surgery to pediatrics, but it didn't fit like internal medicine and eventually hematology. I love hematology because it's like a huge, big puzzle, and oncology that just really you get to be a part of somebody's life during this very challenging time, which I think sounds scary to a lot of people, but you really become part of their family, just like my physicians were part of mine. And so that it really shaped who I am. And I think it continues to shape how I treat my patients and how I have relationships with my patients. And I know it's very cliche, but I would say my diagnosis and my treatment really shaped my life and changed my life. And I think it was meant to be. Looking back, it feels like it was supposed to be this way. And I think that's really the long-winded story to say of why I became an oncologist, but I think it really makes me love what I do every day.
Seems like quite the journey to becoming an oncologist and how you came to fall into hematology specifically. How has your practice been affected by the pandemic?
Yeah, no, the pandemic was also just similarly where you look back in time, and I have these snippets of memories of just these important times in your life. And you can remember sitting around the table with all your colleagues and saying, how are we going to manage these patients and try to give optimal care during this very crazy time? And I think it really made us think outside of the box. And oncology is very, I think, unique. I'm not saying different from all others, but in some way, we never went fully telehealth. A lot of medicine was changed over to either telephone calls or video calls, but we never 100% went that way just because patients had to come into the hospital, get their infusion center treatments. And so a good percentage of patients were being seen in person. And how do we manage that with as little contact with nursing? So you just minimize the touch points as they come in. And I think that was took a lot of communication between the hospital, the nursing, our physicians to really say what the best plan was. So there was a lot of challenges. And I work at the VA, which is a older population for the most part. And I think telehealth for those who are not that tech savvy, and I am not tech savvy. I can barely get the Zoom thing working without unmuting myself on most days. But to try to get our patients to do that was really a real challenge. And so a lot of our telehealth was done via the telephone, which was hard. Those were hard of hearing or relied on kind of a closer contact, reading lips. And we had a lot of head and neck cancers who had trouble speaking just because of dysphagia. It was a real challenge for all of us to try to provide optimal care during this time. And even I think things that were really challenging were also trying to think of what we could manage as an outpatient, what we had to bring patients in for. And then I even remember having this patient with acute renal failure because he just couldn't take that much intake because of his head and neck cancer, and being denied from the emergency room as a way to admit this person because they were so impacted with COVID patients. And how do you treat these acute needs while the whole system is impacted? And so we really had to think outside of the box. And changing therapies that were mostly inpatient to outpatient, I think it made us realize we could do it, that we could. Everything didn't have to be brought into a hospital, or sometimes we switch over to oral pills and chose a regimen that could be done outpatient. I think it really made us look at the data, rethink the data, and decide whether we could still safely do it. So I think for the most part for us has returned to some sort of quote unquote normal. We're seeing a majority of patients in person, and the patients like it a lot better. But I think it made us recognize that we can do things via telehealth. I think there's a lot of patients who drive from far away to come see us. A good portion of our patients live down in Mexico or, live between Arizona and here that make it really challenging to drive. And so it made us realize we could do things via telehealth and still be safe about it. So I think it's still evolving. I think I personally think we'll never go back to 100% in person because I think we recognize that we can do a lot of things telehealth. And in talking to my colleagues who actually treat patients up in Washington, they kind of said that we've been doing this for a long time because they're in a bigger catch area where they're treating the people in Alaska via Washington. But it's made us all kind of change in some way and be flexible. I think that's the biggest thing, to be flexible with our patients. And so I think it's still being affected, but a lot of that has really settled down a bit, but really was a big life-changing, altering time for everybody. But I think it really showed us how we could really band together as a network, and from the hospital down to the people seeing patients in clinic, that we could kind of do this together if we kind of just came up with a good plan.
Sounds like it was a really hard time and that you were very adaptive throughout that process. And everyone has been practicing flexibility during this time, I think.
Absolutely. No, it really required this back and forth push and give, because even in our clinic space, we were then told they had such a large number of COVID patients that they had to take some of our clinic space too. And so it really, really required us to be like, okay, now that we have only 2/3 of our clinic space, how do we then shuffle our patients in and out of clinic? And so it really required communication and flexibility. And I think those times could really show you how well everyone could work together. So it's not to say it was great all the time, but I think you recognize you really have to sit down with your colleagues and say, how can we make everything work with the limited resources that we have, right? And while challenging, I think we all need sometimes those challenges to say, can we do it? Can we be flexible with what we have? And I think it really tested us, and there are some hard times, and I think we were able to manage very effectively.
I love that explanation and just insight into how your particular healthcare system pivoted into dealing with the pandemic and having so many challenges with being able to treat your population. I wanted to ask if you could tell me more about your role at UCSD.
Absolutely. I am my main clinical duties are at the VA, which I think in itself lends itself to medical education. So, and just to explain that the VA is kind of interconnected. It's even on UCSD campus, and it is essentially a trainee hospital. So every subspecialty and every specialty from internal medicine to surgery have trainees in their clinics. And the trainees include medical students, include residents, and include fellows. So I think having that type of setup already lends itself to certain physicians who like working there, just because you will always be working with trainees. But I've always had an interest in clinical education. I think I was a little bit of the black sheep because hematology and oncology is actually very science-based, very clinical trial, very translational and basic science. So I'd say majority of people who come in have some research background in the sense that they either work in the lab or they run clinical trials, or that's their goal. So I came a little bit of the black sheep in the sense that I came in and said, well, I don't know if that's 100% where my interest is. I'm really interested in being a clinical educator. And so I started as a chief resident. And so that you take an extra year, and essentially that year you teach the residents morning report. You run through cases, you do noon conferences, and essentially run with the team of internal medicine leadership, the medical education for internal medicine residents. And so that I think was a great stepping stone for me to say, this is what kind of drives me, and I could spend, my interest at the end of the day was always trying to make new teaching material for the residents to either make the transitions easier or creating teaching cases that could help them understand whatever topic we were discussing. And I found myself loving that portion of it. And so I had a great number of mentors at UCSD that gave me the opportunity to leverage that and leverage my interest and give me opportunities to teach even as a trainee. So I took that into fellowship and kind of continued to do didactic teaching cases with other medical students and residents. And then when I became a faculty, it kind of weaseled more opportunities and kind of inserted myself in certain places and said, can I help? And that has led to leadership positions in the medical school residency and fellowship arena. So in the medical school, I co-direct a case with one of my mentors, Aaron Reed, and we just finished the course, the hematology course for the first year medical students. And in the residency, I'm kind of the core hematology oncology director of their Friday schools. And so I work with the chief residents to kind of come up with their curriculum for their Friday school, which is kind of dedicated Friday afternoons to teaching different topics. And then now I think maybe it's ending my 4th year of fellowship leadership as an associate program director. And so I think it's definitely a more challenging time. I think pre-COVID, we kind of were getting our groove, and then COVID sort of hit. And I think that we're seeing medical education and having to revamp a little bit or a lot of it, just because we're having trainees who are either as medical students or residents have lived through COVID. And as they try to adjust to telemedicine and also having years that were kind of chunked out of their training, we have a lot of interns now that literally for, a good number of months, were sitting at home during COVID and not being taught. And so I think that has created more opportunities for us to kind of pivot and be flexible and learn how to adapt ourselves in this model. We used to, interestingly, have all in-person teaching, and our last medical school was our first COVID time teaching that we did a hybrid in-person and otherwise recorded videos. And I think we're learning the pluses and minuses of all of them. And I think that's what makes it fun. It's still, I still very much enjoy it. And I think it requires that same idea of flexibility within that role to really say, how can we educate the next generations looking forward? And I think it's just fun because I think it keeps me on my toes. I always ask all sorts of questions that make me scratch my head and look into things a little bit more and how we can do things better or change things or keep things the same. So it's been I think, a good fit for me at UCSD.
I was really curious as to how maybe the cancer field or oncology has changed over the course of your career. I've heard how there's been very needed then just a response to the COVID, but I'm curious if you could speak to maybe other things that have been advanced during your career in the field.
Yeah. No, I mean, I think in some way, COVID has also regenerated that idea of, I think, making it to everyone in the world that what the needs of clinical trials. Because in oncology, that's sort of our thing, is we're always trying to look for new drugs. So I think COVID really pushed forward like that. That's why I was amazed by the vaccines and how quickly they're able to accrue so many people. And just the manpower that is required to do that was just awe-inspiring. And I think in many ways kind of really energized people to really think about clinical trials as an option for new drugs and things like that. But oncology has absolutely changed in the last decade. I tell fellows all the time that I'm having to learn things with you because there are a lot of drugs that were not approved or just being approved when I ended fellowship. And to use these drugs, sometimes you turn to your attending or your person that you're staffing with, and as a trainee, you hope that they have this years and decades worth of experience with these drugs. And when these drugs are being approved and kind of in real time, we're kind of learning all together. And that's really been the fun part of oncology, but also the challenging thing as an oncologist. But the last decade, there has been a boom in such drugs, including targeted drugs. So non-chemotherapy drugs that kind of target a particular pathway, and including oral therapies that are better options for older patients. Immunotherapy, which got approved the first one got approved a little bit over less than a decade ago has really revolutionized our world. And the newest sort of immune therapy, CAR T, which has come along, which is just a fascinating way to think about and treat cancer. And so just to the immunotherapy, which I think really has been the biggest change. And prior to immunotherapy, we really only had chemotherapy. And I always, when I teach trainees, I say, who cures, let's say, solid tumors? And it's honestly not an oncologist, it's a surgeon. It's a surgical oncologist who goes and cuts out the tumor. And I think it's mistaken that we can come in with our drugs and be able to cure people. And we can really only do that in liquid tumors like lymphoma or leukemia. And chemotherapy doesn't cure metastatic solid tumors. It just really prevents DNA synthesis. And even if there's one cell left over, it can grow. And so we don't really cure anyone with our chemotherapy. And then along came immunotherapy. And it was really not a new concept. It had been around for centuries. And even I remember being taught in a lecture, they said that people who are thinking outside of the box even try to use small doses of infection or to infect someone with a bacterial infection to mount an immune response. And that showed it slowed tumor growth. Obviously, it fell out of favor because, this is kind of done in I think the early 1900s and people actually got infected, which you kind of don't want either. So, and it, I think it was a little too out of the box at that time, but it kind of made a resurgence. I mean, it still was done in the basic science arena in test tubes or with animals that showed that animals could be immunized against removed tumor cells. So in some way, you could use the immune system to try to control tumors. And then this kind of had a resurgence in the 1980s, and we had interferon alpha and IL-2, which are essentially cytokines that are made by the immune system, but we kind of used it to treat solid tumor. And there was some response. They were FDA approved, and they made patients really sick. Essentially, I called it, because in my training, we actually used it. I call it giving them essentially the biggest infection response. You get low blood pressure, fevers, delirium, renal failure. I mean, it was a full body illness.
Sounds fun.
I know, it was terrible. I mean, I remember just being fearful when a patient would be admitted for this, because oh my gosh, I'm just going to make them feel miserable. It was terrible. But it would slow tumor growth. And so, but it was not fun. And so I would say I remember one of our attendings too at the time said, immune therapy is going to be the wave of the future. And at that time, IL-2 and interferon alpha were the only drugs that were approved. And I think all of us in that room were like, oh, okay, buddy, I don't think so. But along came these checkpoint inhibitors, which are a different way of the body, the immune system. And essentially they're immune checkpoints it's sort of the body's own way of protecting healthy cells, but also killing cells that are not supposed to be there, right? Our body all the time are making mutant cells, and then our immune system goes, oh, wait, that's not normal. And then let's get rid of those. Or, hey, that's normal. So don't do that. So I call it this brakes and gas pedal of our immune system to try to either save the ones that are healthy and try to kill the ones that are, and activate the immune system and kill the ones that aren't. And they're using this system, these new checkpoint inhibitors, to essentially be a treatment for cancer. And so what I call is these antibodies that essentially block essentially they're antibodies, but it's almost like cutting the brakes to the immune system. So it allows the immune system to go. And this has revolutionized our ability to treat cancer. And so I forget the year, I want to say 2000, maybe 11, the first of these checkpoint inhibitors were approved in melanoma. And now if you look at melanoma with these checkpoint inhibitors, where patient survival was so poor, a recent study came out and said that in those advanced melanomas, the average median survival of these metastatic patients is 5 years, which is crazy. I know it doesn't seem like huge to you guys, but in our world of metastatic, non-curable disease, that is amazing. And we're getting these patients who have very long-term remission, whereas chemotherapy never did anything long-term, essentially because eventually the tumors got really smart and would find ways to evade the chemotherapy. The immune system, it's a little, if you just continue to activate the immune system, there's always going to be the gas on. In some way, you're going to have some blanket effect on cells, specifically tumor cells, if they have a response. So these guys are having long-term remissions. And one of my patients is a non-small cell lung cancer, and the average survival was about a year. And I just saw him in clinic with a resident. I'm like, and here he is 7 years later,
Awesome.
and he's alive. Yeah. And so it's just watching these patients. And it's funny because that whole patient interaction with him and the resident was not talking about his cancer, because his cancer had complete remission now for years, was now that he's like 82, he had worsening dementia. And so I'm like, our whole appointment was really talking about totally non-cancer stuff because his cancer was so well controlled and metastatic. He had essentially blown through all chemotherapy options. And he went on a clinical trial at the time at UCSD for the first immunotherapy. And then once they got approved, he came back to the VA and he's continued on that drug. And so I'm thinking, you see these now, there are not all home runs, but you're seeing these patients who will have this very long-term remission, dare I say cure, but remission for long-term. And so I think immunotherapy in that way has really changed our ability to treat. And chemotherapy used to be really hard to take if you were older and couldn't tolerate the side effects and the bone marrow toxicities. But immunotherapy typically, now they do have a good, on a whole, maybe 10% of severe immune adverse effects, but we have 80-year-olds and 90-year-olds on immunotherapy with just a little bit of fatigue. So you're able to offer treatment options to a larger patient population that weren't offered that before. And so that, I think, just is so amazing and such a story to tell. And that, I think, it's just the beginning of how we manipulate the immune system. And I think oncology in that way now we're dealing with sometimes a chronic disease, but also oral therapies that allow us to treat younger and younger, not younger, but more patients that wouldn't be able to treat with chemotherapy.
Ida, as I was listening to you talk about immunotherapy, I had this visual image of a bouncer at a nightclub. And I'm like, you called them checkpoint inhibitors. I'm pretty sure bouncers need that as their title. That they are now checkpoint inhibitors for the nightclub. But might be a silly way.
We always need an analogy, because when we're telling our patients how, and I tend to use the gas pedal and the brakes, but like we're always needing a way to tell our patients, and when we tell them about the drug and consent them for the drug, and maybe I'll use the bouncer approach.
I'm for it.
Yes, but it's certainly been fun because you feel like you're part of this ever-changing field, and it's fun, creates more ideas for a person who's more basic science, translational science minded, to go back in the lab and ask these questions of how can we manipulate the immune system or more to really find new novel treatments. And I think that's the fun part about, but as a clinician, to be able to use these drugs and see the actual effect and have the quality of life maintained for these patients is just, it's been so rewarding. And I think it's been so rewarding to also see the excitement in the trainees that come into clinic, because sometimes the trainees always see the patient. They tend to do a lot of inpatient. And so all they see is like the bad effects of immunotherapy. Because don't get me wrong, there are bad effects of immunotherapy if they get one of those immune toxicities. But then they're like, oh, why do we even do this? And then they come into our clinic and we're like, oh, this is why, because the other 98% of patients that you don't get to see are kind of blipping along in clinic and doing quite well on immunotherapy. So it's been really rewarding from all ends, from a scientific side, but also from a clinical side.
So it sounds a little bit like chemo in a way, because chemo is not fun and it does have benefits, but then there are those like percentages like in immunotherapy that also have like really adverse effects.
Mm-hmm. Mm-hmm.
Is there any like long-term effects of immunology similar to chemotherapy?
Yeah, there are. So it's the majority of patients roll out with a little bit of fatigue. Some people get it when I tell patients, majority are just going to say, oh, I feel a little bit of fatigue, and they may or may not have to start some thyroid medication because the immunotherapy can essentially, by cutting the brakes, you allow the immune system to go unchecked for a little bit and in hope that it kills the cancer, but in some way it can also start to inflame a lot of other organs, lung, colon, skin. The most common is the thyroid. And so people tend to have to go on some sort of thyroid replacement. And that's the majority of patients. Here's a little thyroid replacement, a little bit of fatigue that doesn't affect their life. But there's that percentage of patients who get the terrible side effects that force us to hold the therapy and then have to actually stop the immune system with some steroids and plus or minus some other medications depending on the side effect. And those are the most challenging cases. Most of it you're able to reverse with some steroids, high doses of steroids. But there are a portion of patients who kind of have long-term effects, especially if you can, in sort of that risk benefit. We have one patient who literally has almost, we've knocked out his pancreas. So he's now on insulin, and it's a very rare side effect, but he got it. And then he also has a rheumatoid arthritis or inflammation of the joints. And so he's on some anti-inflammatories like methotrexate to try to slow it down. And this is just his long-term effect. And we even tried stopping stuff, his immunotherapy, and that honestly didn't help. And so sometimes I've seen chronic fatigue too with these drugs, that there's just a subset of population that just because the drug's been in there and it's stimulated the immune system is still going. And there's not in this subset of patients a good way to stop it, minus putting them on high dose steroids all the time, which we don't like. And so, yes, there's a subset. What's interesting is some of this subset actually has, because the immune system keeps going, control of their disease. And it's this trade-off, right? And this one bladder cancer patient I have has had no evidence of disease for years, but he lives with kind of chronic joint problems and chronic fatigue. And it's sort of that trade-off that, man, chemotherapy, you were metastatic and chemotherapy would have never had this long-term effect, but he's living with kind of chronic symptoms. So I think it's a very challenging, while we're very rewarding, can be very challenging for quality of life for a subset of patients.
So it sounds like it kind of like boosts the immune system to like a super level for a period of time, because you said it removes those limits. And on this note, I have a different question for you. How do you incorporate a whole person approach to treatment?
Yeah, no, that's I think a great question from the get-go. We even try to incorporate during our new patient appointments, whether we're going to start chemotherapy or immunotherapy or targeted therapy and oral therapy, because I think you don't know what's going to happen. And I always say to my patients, I wish I had a crystal ball to say what's going to happen in the future in terms of side effects, whether you're going to be one person that breezes through. I mean, I had an 80-something-year-old patient that breezed through, treatment with chemotherapy and had almost zero side effects. And 40-year-old person that had major side effects with the exact same chemotherapy, the exact same dosing. It's so hard to anticipate all the potential side effects of any treatment options that you offer. And so I think it takes a family and a village of people to treat the patient as a whole. And I think some people include, from a social worker to a dietitian or a nutritionist. For oncology, we have case managers and we have infusion center nurses. We have psychologists and psychiatrists, supportive care via palliative care. And that's all in addition to the physician seeing the patient. And so, and I also believe that the body is just really one aspect of care, but the mind is another. And that mind includes what you put into your body. And so as a oncologist, we only have, unfortunately, I wish things were different, but only so much time we have per patient in our schedule. And and to try to fit all these aspects of their financial needs to their home needs, to their diet needs, their sort of where their mindset is really, unfortunately, challenging for us to be able to do it all in that period of time and give them the patient what they need. And so I think from the get-go, when we see the patient, we actually have them meet with our case manager. And if there's any specific needs, we have that our case manager kind of help them kind of fit into the right family member, if you want to call it that. So from the nutritionist to the social worker, we try to give them all those options, even our psychologist, the options from the get-go when they first meet them. And so on our checkout sheet, we'll even have everyone listed there, from the case manager to the social worker to the nutritionist. We don't have our behavioral health or psychologist number on there, but we do verbally offer it to them. And so I think thinking about things as a whole, even though it's very overwhelming on that first visit, we tend to then kind of reinforce as we go along about what the patient needs, because I think the treatment is just one aspect of it. And there's so much more to what the patient needs. And so I'm all about the whole person approach. And I think while overwhelming, if you are able to do in small pieces and you build that rapport with the patients, then they start to trust other people and allow those family members to really support them. So I think it really honestly takes a village, and and the patients really, I think, like that because they feel lost sometimes. And if they find that there's people to catch them in different arenas, I think what's the most challenging is really just the logistics of trying to, who do I reach for this and where do I go to? But once they kind of get the hang of it, and along with our case managers who are kind of double as nurse navigators, they help them navigate through this portion. And once they kind of get settled, it really is, it should be a whole person approach.
Yeah, it sounds like there's just a large team that's like providing care. That oncologist is just, as an oncologist, you're a part of like a large collaborative team that's providing care to these patients.
Absolutely.
As an oncologist, I just wanted to ask since I'm a nutritionist, what in your experience are kind of questions that maybe patients ask you, and what's like kind of like the protocol for an oncologist and as far as sharing about nutrition?
Absolutely. No, I mean, I think that's a great question. And we get this question a lot. I'd say if we were asked about, I think the most common thing we're asked about is diet and what should I eat? And so this is just my opinion and my approach to my patients is that in oncology, I think also for diet, it's something patients can also control. And so I think that gives them the control back with someone helping them to make choices that will fit their needs. But I think patients are always asking me, what should I eat? And I think family members are also asking because they like to cook for them, and they like to, the same way I cook to make my family happy. I think that's what family members do to people who are not feeling well. And so
have that comfort food.
Yeah, that comfort thing. And so I think it really does give patients back that control. And I think the most common thing is asked about the diet. The other thing is the neutropenic diet. I would say also from an inpatient side, I get asked a lot about what that means. And maybe I'll answer that question first and then answer the second one. Is the neutropenic diet, I think it's never been by any scientific way proven to be, I don't know if beneficial is the right word, but does it make patients sicker to adhere, or does it make patients safer to adhere to the neutropenic diet, which is essentially when patients have very low white counts, to not eat kind of foods that potentially can introduce bacteria. And I find it a little bit challenging. And I would say my practice now is different than it was 10 years ago when I said, absolutely not, you shouldn't eat all that stuff. I think I always say work with a nutritionist, but my big thing is if you are on a neutropenic diet because your counts are low, to think about, even if you do want fresh things, because it's really hard to then start limiting patients on their diet when they're really not hungry and they want certain things, you want calories in, is that I say, hey, our goal is not to introduce foods that potentially are not washed clean and still have bacteria on the outside or the inside, like raw fish or raw meat. If I still tell patients not to eat raw fish or raw meat because that's, unfortunately, you can't fix that portion of it. But I think like raw vegetables and raw fruits, I tell patients, if you want to do that and that's really what you're craving, do it at home where you're not don't buy it from like the grocery store where you don't know who washed it. But at home, you have a person who's going to be very diligent about washing that spinach or those strawberries very carefully. And so I tend to maybe be a little more lenient just because I don't always have patients who limiting their diet should be living their diet is even harder. But I think that's changed. My voice on that has changed over the years just to make sure patients still have some options. In terms of the diet itself, I always lean on the nutritionist for supplements because oftentimes patients don't want to eat but the one thing I say over and over, what's been proven in any field of oncology, whether that's leukemia, bladder cancer, lung cancer, is that we need to keep the weight stable. Weight loss is absolutely a poor prognostic sign. And so to really be cognizant of that very early. And so that's where I absolutely then use my nutritionist dietitian to say, our goals are to keep the weight stable. However that is, to work it out with the patient to come up with something that is very tailored to them, whether that's additional supplements or not, or finding higher calorie foods that are not quite as, feeling like you have to eat a full meal. So unfortunately, it takes a lot of time and also expertise that I don't feel like I always have. And so I always, like from the get-go, will refer pretty early. And even cancer patients who are cured, I'd say, I will tell you, patients have come back and said, boy, that nutritionist was the best. And like 4 years later, I wish someone had told me that. One patient who had colon cancer, but he also has a familial polyp syndrome that required him to remove his entire colon. And so he had changes in bowels all the time. And we couldn't as a doctor, I'm always like, okay, let's try medication. And he's like, the one person who made this change in my life was the nutritionist who's like, yeah, dude, you don't have a colon, so we need to change your diet. And he's like, it was a miracle. And now I can kind of feel like I can have a life where I'm not relying on a bathroom. And so I'd say even from our cured to our mostly treatment patients, it's a big part of our family.
That's really, that's awesome that you've been able to like lean on the dietitian more and in providing that. And the malnutrition piece is really big with cancer patients because, you're just not hungry during like the chemo.
Yeah. And and I suppose this is where my history, I have much more empathy for it. Cause I remember distinctly when I was sick, I'm like, if there was a pill that had 2,000 calories in it, I would take it. I mean, right? I mean, do you remember like if they had a pill that could give me all the calories, I will take it. And like you would never ever in your life, people would stare at you if you were crazy because food is such an important part of our lives that make, that little receptor in our brain say, I'm happy but during treatment for whatever reason, it just, that part gets shut off. So it's really challenging to, I think as family members too, to understand that portion, to be like, I don't know why he's just not eating. And so it's a huge part. And I think having that sort of empathy factor makes it a little bit more understandable for me. But this is where I kind of lean on other people to say, maybe there are ways outside of our typical way of thinking to get nutrition in.
I like how you spoke to the whole person approach as needing a village. My mind went to like, does that make us the village people? I mean, there's a cop, a construction worker. There's all these jacks of trade, so to speak, that are going to maybe speak to usefulness. Maybe that's what the village people were trying to then convey there.
Maybe.
Not just promoting the YMCA. But I was going to ask if there was any other aspects of your personal cancer history that has changed your approach. I think you've spoken to quite a bit of that, but I just wanted to maybe circle back to that and see if there was anything you wanted to add.
Yeah, I mean, I think to Dustin's question on the nutrition, I think I'm definitely much more empathetic and knowledgeable. And I'll even say that I'll even explain it to family members. Like, it's really hard to understand the idea of not being hungry, but it's a real phenomenon. And I think it's really just to take that small bit of time to tell family members it's not that he doesn't want to, he or she doesn't want to, but it's really a part of the disease. And so I think it's made me take those moments in the clinic when we're kind of on a one track agenda to try to talk about treatment options is to really acknowledge, I think, the hardship on the patient, really acknowledge the hardship on the caretaker, because I think that is also got a different set of challenges. And it recently had a patient who really didn't want to take supplements. And I don't usually share, but I said, and when I was 16, threw my supplements down the toilet and was only caught when my mom was cleaning and saw pink flecks of Ensure in the toilet that she recognized I was flushing it down the toilet. But recognizing, like, I get it. We do things and we want that control back in our life, but explaining what the goals are and trying to, I think I'm much more shared decision making, because I think there are times where we as an oncologist can come in and say, this is our treatment plan. And because the data shows that, and so we're going with that, that is not, tends to not be my only, I have to take the whole person into account of what are their goals? What kind of social situation do they have? Is there an option that could be more tolerable for them, given their goals? Obviously, I still want to follow what is standard and what will provide, hopefully, the longest life. But there are plenty of times of patients who say, I understand it's going to be longer life, but coming back and forth to a hospital is not my plan. And then we have to pivot and to listen to the patients, because as long as my kind of thing is, as long as I've educated you on what would be typical standard and why we're pivoting and to fit your goals, I think that shared decision making, I think has changed my history has changed how I practice, mostly because I think patients want to be heard. But I think it allows me a different empathy, not to say every other person who doesn't have this history, there isn't, but I think it's definitely shaped how I approach the patient differently than what I think then the literature says, which is sometimes this data is better than this data. And so this one is what we should go with. Because I do think quality of life matters immensely in what their goals are.
Well, Ida, I just wanted to thank you for sharing your expertise. And I also wanted to share that we had been connected by our physicians, through our shared healthcare system treatment back, just a couple of years ago,
Yeah, a couple years ago.
The thought that we were kind of in that middle, like you were describing. I was 19 when I was diagnosed, and that's kind of how our paths crossed. And I think I wanted to just share that it's just been really awesome to see your career path and see how you've been able to share your medical knowledge with us and have this conversation.
Yeah, no, I think, wow, yeah, it's so rewarding to see the two of you have this history, and it in both your cases also shaped what you did and how you approach your practice. And I think history shapes who you are and the people that you meet. And I just really commend the both of you guys as well for wanting to share your history and what the wonderful things you're doing through this podcast too, to share with others on a totally different platform. I think people, you scratch the surface, everyone has something as part of their history that has defined them, and how we go forward using that, whatever history that is, to define them to do whatever good in the world. And I share that same sentiment with you two. And I just think it's amazing that we get to share this and now with others, and hope that in some way, even at 19 and for me 16, inspire each other to persevere and go on to have a healthy career and a healthy family, however that's made up. So it's been it's been rewarding for me as well.
Well, thank you very much for your time. And like I said, I really do appreciate being able to then see your career trajectory and your growth. So we will end there.
Thank you.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey.